Starting with the neonatal jaundice, which is a very important topic as far as neonatology is concerned in pediatrics. So, jaundice. So, when we talk about jaundice, jaundice is seen in about 60% of all the newborns, and out of which, in 80% of all these, it is mostly a physiological jaundice which heals by itself. Now, it's again the most common cause of readmission or most common cause of morbidity in first week. So this is very important. Now, for the jaundice to be visible, what should be the levels of serum bilirubin? So levels of serum bilirubin that is needed is more than 5 milligrams per dl or more than 5 milligram percent simply. Now, after that there is a classification of jaundice. As we all know, there is a physiological jaundice and pathological jaundice. Talking about the physiological jaundice, it appears in about 1 to 3 days. So it generally appears after 24 hours and it peaks at about 3 to 5 days. Here, the levels of unconjugated bilirubin increases. So this is very important that levels of unconjugated bilirubin rises. Only unconjugated bilirubin levels rise and not the conjugated bilirubin, because most of obviously this physiological jaundice is caused because of hemolysis, right? Now, is are the palms and the soles of the body involved? They are never involved in case of physiological jaundice. The second type of jaundice that we know is the pathological jaundice. Pathological jaundice appears in less than 24 hours. This is very important, and it lasts for about 3 to 5 weeks. Now, in pathological jaundice, however, the levels of unconjugated bilirubin as well as conjugated bilirubin can rise. So either the levels of unconjugated bilirubin can rise or the levels of conjugated bilirubin can rise. Now, what are the different causes of rise in unconjugated bilirubin levels? The unconjugated bilirubin levels, they can rise because of increase in secretion of bilirubin, right? If the bilirubin is secreted more, then UCB levels can be increased. So the unconjugated bilirubin levels, the most common cause of rise in unconjugated bilirubin levels is the erythroblastosis fetalis, which is nothing but the maternal antibodies that are produced against the fetal RBCs. Then the next is the various hemolytic disorders like the hereditary spherocytosis, G6PD deficiency, extravasation of blood like cephalometoma that can also lead to it. Then intraventricular hemorrhage can be present. Infant of diabetes mother can also present with unconjugated pathological jaundice, and delayed cord clamping can be another reason for rise in unconjugated bilirubin levels. The conjugated bilirubin levels, they rise. Now, before that, the unconjugated bilirubin is converted into conjugated bilirubin with the help of obviously an enzyme. And what is that enzyme? That enzyme is called as UDP-GT, that is UDP glucuronide transferase enzyme. So if there is a deficiency of UDP glucuronide transferase, then that will also lead to rise in unconjugated bilirubin levels, obviously. So what is that deficiency called as? That is called as the Crigler-Najjar syndrome. So Crigler-Najjar type 1, Crigler-Najjar type 2. Crigler-Najjar type 1, where there is a 100% deficiency, and Crigler-Najjar type 2, where there is a partial deficiency of this enzyme. Apart from that, some genetic conditions, that is chromosomal abnormalities like Down syndrome, can also lead to increase in unconjugated bilirubin levels. Now, talking about the conjugated bilirubin, the conjugated bilirubin can increase, and there can be two causes. There can be either a non-obstructive cause or there can be an obstructive cause. So conjugated bilirubin levels are increasing. That means the bilirubin is conjugated, but however it is not expelled outside the body. That is, it is obstructed somewhere, or it may be some non-obstructive causes, right? What are non-obstructive causes? These are mostly the viral diseases, right? So for example, you have hepatitis and all. Then the next is congenital TB can lead to it, galactosemia, then fructose disorders, fructose metabolism disorders, cystic fibrosis. So these are the non-obstructive causes of increase in levels of conjugated bilirubin. Then what are the obstructive causes? Obstructive causes, they can be even further divided, whether the obstruction lies in the liver itself, that is it is intrahepatic, or whether the obstruction lies outside the liver, that is extrahepatic. Now whenever we talk about extrahepatic, the most common thing that we should understand that extrahepatic biliary atresia, EHBA, extrahepatic biliary atresia, it's the most common cause of liver transplant in newborns. Then, while in intrahepatic obstruction, it may be because of Alagille syndrome or you have Caroli's syndrome. So these are the different syndromes that can lead to increasing levels of conjugated bilirubin. Now, very important, obstructive jaundice. When we talk about this particular term, that is obstructive, that means the bilirubin is conjugated but it is obstructed. That is, it is not able to come out of the liver or out of the gallbladder, whatever. So this will lead to effects on the body. For example, the stools, they are imparted color because of the bilirubin. Now, because of obstructive jaundice, the stools, they become clay colored or they will become pale colored. So clay colored stool or pale colored stools on microbiological examination or on asking the patient, then that means obstructive jaundice is present. Similarly, the urine will obviously become dark yellow in color. So these are the two important findings in the obstructive jaundice, that is clay or pale colored stools and dark colored urine. So this is a very important hint or a clue that is given in exams. So till now, how can we diagnose the jaundice? So we know that jaundice, it can be of two types. It can be physiological jaundice or it can be pathological jaundice in a newborn. How to differentiate? So we already know that if the child is coming in less than 24 hours, then it's a pathological jaundice. If the child arrives in 1 to 3 days after birth, then that is mostly a case of physiological jaundice. Now, apart from that, in pathological jaundice, palms and soles can be involved, while in physiological jaundice, palms and soles are never involved. But however, palms and soles, for them to get involved, the serum bilirubin levels need to be very high, but the newborns patients, they arrive early. Now, the pathological jaundice is further divided into unconjugated bilirubin levels increase or whether conjugated bilirubin levels increase, right? So this can be found out by using lab investigation. So by lab investigation, we can find out which type of pathology is present, whether it's rise in unconjugated bilirubin levels or rise in conjugated bilirubin levels. Whether if it's a rise in conjugated bilirubin levels, then further we can find out whether it's a obstructive jaundice or whether it's a non-obstructive jaundice. How? Because in obstructive jaundice we have clay or pale colored stools and dark colored urine. So this is how we'll basically find out whether which type of jaundice is there. So this is how we need to progress while in the workup of jaundice. Now there are some other terms, like there is something called as the breastfeeding jaundice. So breastfeeding jaundice, it is also called as the suboptimal intake hyperbilirubinemia. That means the breastfeeding is not adequate enough. So in these particular conditions, the enterohepatic recirculation, it increases, and because of enterohepatic recycling, it increases the bilirubin levels, they increase. So that is called a suboptimal intake hyperbilirubinemia. There is more than 10% weight loss in first week. Now we know that whenever an infant is born, in the first week there is up to 10% weight loss, and after that up to 10 to 15 days the infant again regains its weight. Now the next is the breast milk jaundice. So what do you mean by breast milk jaundice? Now the breast milk, it consists of an enzyme that is called as the beta glucuronidase. Beta glucuronidase, it helps in deconjugation. So in breast milk jaundice, the UCB levels, that is unconjugated bilirubin levels, will increase obviously because it's a deconjugating enzyme. So unconjugated bilirubin levels will increase. Now very important is that this breast milk jaundice is a diagnosis of exclusion. So that is, if the jaundice is more than 3 weeks and you have ruled out that it's not a pathological jaundice, then you can say it's a breast milk jaundice. It heals on its own. Okay, so we don't need to stop breastfeeding over here. So in both these cases, the breastfeeding jaundice is because of suboptimal intake, and the breast milk jaundice, in both of them we need to continue with the breastfeeding. So breastfeeding should be continued in both the cases. Now moving on to the next, that is, what are the neurological manifestations if there is a high levels of serum bilirubin? So which is the most common side affected? It's the basal ganglia, and what is that condition called as kernicterus, right? There is something called as acute bilirubin encephalopathy. So what happens is acute bilirubin encephalopathy, the tone of the muscles increases, so that is called as hypertonia. And because the tone of the muscles increases, it gives a arched position of the back, that is called as opisthotonus. We all know this, right? And also a high pitch cry. These are some of the features of acute bilirubin encephalopathy. Now, what are the different investigations that can be done in neonatal jaundice? So, the first thing is by clinical examination through visual assessment, and this visual assessment, it is by the Kramer's rule. So, Kramer has divided of this body of neonate into various zones. So this zone number 1 that consists of the head and face, the zone number 2 which consists of the chest, the zone number 3 which consists of abdomen and pelvis, the zone 4, right, the zone 4 which consists of the limbs, and zone 5 which consists of the palms and soles. Now very important is if there is a yellowish discoloration that is found in that particular zone, then we can find out the approximate levels of serum bilirubin. If zone 1 is involved, then the serum bilirubin levels are 5 to 7 milligrams per dl. Then if the chest is involved, then that means 7 to 9. If the abdomen and pelvis is involved, it is 9 to 11. If the limbs are involved, then that means up to 11 to 13. And if the palms and soles are involved, then it can be 13 to 15, or it can be more than 15 milligram percent will be the serum bilirubin levels. Apart from that, we can use this device that is called as the transcutaneous bilirubinometer, that is called as TCB, transcutaneous bilirubinometer. So you press this device against, generally sternum is used. Now this will give us the approximate values of serum bilirubin. This is better as considered to visual assessment by Kramer's rule. But however, in high levels of serum bilirubin, this becomes unreliable. Now the next, that is other investigation that can be finding out the laboratory values of bilirubin. Okay, now the next, how will you manage the patient? So the management, whenever a newborn child is there, we are going to screen for the jaundice every 12 hours for up to 3 or 5 days. We are going to find whether it's a serious case. What do you mean by a serious case of jaundice? Serious case of jaundice, it means that either the palms or the soles of the child, they are yellow in color, or if the child is readmitted, or the child is basically present over there only, so it is appears within 24 hours, or if there are signs of neurological signs, for example acute bilirubin encephalopathy signs, if hypertonia is seen. So in these particular cases, it's a serious thing. If these signs are present, then we have to directly start phototherapy. If these signs are not present, then assess if the jaundice is pathological in nature. If the jaundice, assess whether the jaundice is pathological in nature. If the jaundice is pathological in nature, then again start phototherapy. If it's not, then further assess whether it's physiological jaundice. And if it's a physiological jaundice, then we don't require any treatment. Now, what do you mean by phototherapy? So phototherapy is nothing but, we have all seen that this is the blue colored wavelength is used, and this converts the bilirubin into lumirubin. What is that process called as? What is that mechanism called as? That is called as the structural isomerization. So structural isomerization is a very important mechanism. After also photoisomerization or photooxidation is present, but very important is the structural isomerization. Then what is the wavelength that is used? The wavelength that is used is 460 to 490 nanometers. Nowadays LED lights, they are also used. Now, when will you consider it to be effective in nature? It is considered to be effective if the distance between the source of light and the neonate, it should be at least 30 centimeters. At least 30 centimeters should be the distance. Now, very important point is that this phototherapy, it should be used only when the levels of unconjugated bilirubins are high. Only if the levels of unconjugated bilirubins are high, we can go for phototherapy. If you use the phototherapy in pathological jaundice where conjugated bilirubin levels are high, then that can lead to bronze baby syndrome. That can lead to diarrhea in the patient. Then again, in this picture we can see that the eyes are covered, the gonads are covered. Why? Because that can lead to gonadal toxicity, or in the eyes that can lead to retinal toxicity. Now coming to the management protocol again. So in the management protocol, start the phototherapy as soon as possible, and then further we are going to assess the normogram. So this normogram is assessed. Now what is this normogram? Over here you can see this is the normogram. This normogram tells us whether we should continue the phototherapy or we should stop the phototherapy. So this is a normogram. For blue colored one is for preterm, and the black colored one is for the term. Now if the serum bilirubin levels, they are counted at a particular time interval. Serum bilirubin levels, they are calculated for a particular time interval. Now if for example at 72 hours the serum bilirubin levels they fall, it's a term neonate and the serum bilirubin level it falls somewhere over here, that is below the curve, then in that particular case we can stop the phototherapy now. But if still the serum bilirubin levels they fall somewhere above this curve, then we have to continue with the phototherapy. If they are very high, then go for exchange transfusion. The exchange transfusion it consists of uh, then in case of erythroblastosis fetalis, that are where maternal antibodies are present, we go for double volume exchange transfusion, that is 160 to 180 ml per kg of blood is exchanged. This is generally found when the cord hemoglobin levels they are less than 10, and if the bilirubin levels are more than cord bilirubin levels are more than 5 milligram per dl. So we can also directly know the phototherapy cutoffs, that is we can by heart those phototherapy cutoffs and exchange transfusion cutoff in term units. So in term units, if it's a term unit of 1 to 2 days, then the phototherapy cutoff will be more than 15 milligram percent, and exchange transfusion cutoff will be more than 20 milligram percent. If it's between 2 to 3 days, then it is more than 18 milligram percent. Here it's more than 25. Then in more than 3 days, more than 72 hours, then the phototherapy cutoff is more than 20 milligram per dl, and in exchange transfusion cutoff it still remains to be more than 25 milligram percent. So this is how we calculate the phototherapy and exchange transfusion cutoff in case of term neonates. Now what about the preterm neonates? So in case of preterm neonates, we have a simple formula that in case of preterm neonates, the phototherapy cutoff that is equal to 1% of the body weight in grams. So whenever I say a preterm neonate, it's mostly less than 1.5 kg in body weight. So if it's 1400 grams of body weight, then what will be the phototherapy cutoff? The phototherapy cutoff will be 14 milligram percent, will be 14 milligram percent. If it's 1300 grams, then it will be 13 milligram percent, right? And what will be the cutoff for exchange transfusion? Cutoff for exchange transfusion is phototherapy cutoff plus 5 milligram percent. So in this particular case it will be 19 milligram percent. If it's a 1300 gram weight baby, then that will be 18 milligram percent. So in this way we are going to find out the cutoffs for the phototherapy and exchange transfusion, and then we are going to assess it by normogram charts, and we are going to stop the therapy or we are going to continue the therapy. So in this way the management for neonatal jaundice is done. And so this is all about the very important topic, that is neonatal jaundice in neonatology.